Welcome, welcome, welcome. My name is Pamela Stewart Wagner, and I'm a member of the Allen Temple Baptist Church and also a member of the Health Education Ministry. On behalf of our senior pastor, Reverend Jacqueline A. Thompson, and our Pastor Emeritus, Reverend Dr. J. Alfred Smith, Sr., we would like to thank you very much for attending this workshop on our virtual symposium on Alzheimer's versus dementia. But before we get started, we would like to get a word of prayer from our deaconess, Letty Barber. Letty has been a longtime member of the Allen Temple Baptist Church and is very supportive of all the different programs we have at our church. So take it away, Letty, for our opening prayer.
Thank you. And I wrote your name down, Pam, so I wouldn't forget. We are going to just do a word of prayer. We will always, always remember you, Lord, in all that we do. We thank you that you are looking out for us today. You allowed us to wake up this morning and to be here. Lord, I know I have questions, and I hope the other people that are going to be joining us will have the same information, looking for information on Alzheimer's and dementia. Lord, we just pray that the people that are going to be presenting give us something to use in our life, daily life. Lord, there's so much going on, so much in terms of Alzheimer's, things that we used to just say people were just losing their mind, but we didn't know that were medical and issues and diseases dealing with this. So Lord, I'm looking forward, as I hope all the others are looking forward, to information to help us, the ones that are caregivers and the ones that may, in fact, be caregivers in the future. Lord, we thank you for the two people that are bringing information to us. We thank you for the pastor for knowing that there was a need. Lord, she saw the need, and the health ministry is filling that need. So we applaud them for all that they are doing to bring this information to us. We pray that everyone gets something from this event, and I know I will. Thank you, Lord, for all you do. In Jesus' name, amen.
Amen. Thank you so much, Letty. Pastor Jackie, did you want to say anything before we get started? I see you're on.
Thank you, Sister Pam. Good morning, everyone. For those of you that I can see and those of you whose icons I can see, I just wanted to come on and first of all welcome Nurse Scott and Dr. Windom, and thank them so much for taking the time out of their schedule to have this conversation with us. And for all of you who have taken time this morning to join us, we are deeply appreciative, and I am deeply appreciative to the Health Education Ministry for engaging this issue. As you all know, my mother lived with Alzheimer's dementia. I was a caregiver to her while at the same time leading Allen Temple. And there are so many of our members who are dealing with that. And we also have members who are struggling with the disease themselves and haven't really come to the conclusion as to what's going on. And so I want to thank our area experts for coming on. I want to thank Deacon Goodman and his team for pulling this together. And I pray that this is a very fruitful discussion that we can continue to share out widely to those who need a sense of encouragement, a sense of empowerment. And I hope that we also get a better idea of how we can support our caregivers, because we have lots of folks who are giving care and they continue to need ministry as they minister to others. So thank you for yielding just a few moments for me to be able to greet everyone. Take an opportunity, if you're on social media, share this link, send a text to someone, send this link to someone, ask them to join us, because we hope that we can get this conversation spread widely. Thank you so much and have a blessed and fruitful time of sharing.
Thank you very much.
Thank you,
So today I'm going to be your mistress of ceremonies, but before we get started, I'd like to ask everyone to please put themselves on mute so that when the speakers are speaking, we don't have interruptions with phone calls and all the other things. But let me give you a little information about Dr. Windom. Dr. Charles Windom, MD, is an assistant professor of neurology at the University of California, San Francisco Memory and Aging Center. In his current role, he participates in the clinical care and management of those who present the center with memory decline and cognitive changes. Dr. Windom also has a passion for serving underserved communities and has been leading outreach efforts within multiple San Francisco Bay Area communities. Dr. Windom seeks to further understand diseases like Alzheimer's among all populations, emphasizing the significance of certain blood tests and brain imaging tests in those with concerns about their cognition. In addition, he seeks to understand the impact of social determinants of health, such as work, play, and life and cognition. Through his work in these various efforts, Dr. Windom's ultimate career goal is the elimination of disparities in neurodegenerative disease and dementia. Dr. Windom received his bachelor's degree from Princeton University before obtaining his degree from Rutgers Robert Wood Johnson Medical School in New Jersey. He completed his residency training in neurology at the University of California, Los Angeles, also known as UCLA, and his behavioral neurology fellowship at the University of California, San Francisco Memory and Aging Center. Welcome, Dr. Windom.
Thank you so much for the very kind introduction and the warm welcome. Thank you all for your attendance this morning. And thank you so much to the leadership for allowing me to have the opportunity to be able to speak. So I'm going to speak about a couple of things this morning, and hopefully they will be insightful. Hopefully they will be informative to you. We're going to talk about Alzheimer's and dementia. We're going to talk about information that you really need to know now that we are in a new era. We are in the therapy era with regards to Alzheimer's disease, something that many of us may be familiar with, some of us may not be familiar with. And we're going to try to build a bit of a foundation of knowledge that you can operate off of in this new era. So when we think about Alzheimer's and dementia, we have to back up a little bit. And what I mean by that is we have to first understand and think about what does it mean for the brain to age in and of itself. We're very familiar with aging in general, very familiar with parts of our body aging. You know, our joints feel differently than they did 20, 30 years ago. We may have different heart conditions or lung conditions compared to when we were 30 or 40 years younger. Again, a byproduct of aging. But what does this mean from a brain standpoint? It's important to understand that there are many different parts of the brain, and that as the brain ages, these different parts change as well. So the way that we kind of think about how the brain is structured is twofold. We think about kind of the outer part of the brain, and then we also think about kind of the inner part of the brain. So many of us, I think, are familiar with the outer part of the brain. This is the picture here on the left where you see all of the different folds and grooves and things like that. And when we think about this outer part of the brain, there are kind of these big parts, these big chunks that we call lobes. There's the frontal lobe, which is in the front. There's the temporal lobe, which you have one on either side. There's the occipital lobe, which is in the back. And there's the parietal lobe, which is kind of in the back and the top. And then underneath the big stuff up top, you have also structures like the cerebellum and the brain stem too. And so these outer kind of structures, these outer lobes, cover a lot of inner structures or deeper structures. That's what's pictured on the right. And what we think about so often when we think about the inner structures or the deeper structures is what is called the limbic system. And the limbic system is critically important in part for memory. So the limbic system is composed of things like the thalamus, the cingulate gyrus, the fornix, a lot of interesting names, the hippocampus. Many of these structures work in conjunction with one another to actually form memories. So the hippocampus in particular is absolutely critical for new memory formation. There is a famous scientific case of an individual who had very bad seizures. He had very bad epilepsy. And one of the ways that you can reduce seizures is you can actually find where they're coming from in the brain, and you can remove that part of the brain. This is actually how we treat epilepsy in children who have very bad epilepsy. This individual actually had epilepsy that was kind of coming from the part of the brain where the hippocampus is near. So they removed both of his hippocampi, both sides of the brain, they removed the hippocampi, and he was actually incapable of forming new memories. He was kind of stuck in time. Everything he had learned up to that point, he could remember, but could not form a single new memory. So this is how we know about all of these different structures and why they're so important with regards to the anatomy of the brain and brain health. And so given this information, given all these different structures, we understand that just like the rest of the body, the brain changes and ages over time. So on the right here are pictures. You're looking at pictures of an MRI scan. The picture on the left is somebody from 20 years, somebody who's 20 years old, somebody who's 90 years old on the right. And the pictures up top are if you were looking at the brain basically from above and you kind of made a clean cut through. The pictures on the bottom are if you were looking at the brain face on, if you made a clean cut through the face and you were looking face on. And you can see how when you compare the images on the left of the 20-year-old to the images on the right of the 90-year-old, they look very different. The images on the left, you see a lot more of kind of the gray and white. You see less of these kind of dark spaces. We all have these dark spaces. These are called ventricles. But by the time we become 90, these have become much larger in size, and you can see shrinkage of the gray and kind of the white coloring, which is the actual brain matter. And this picture from the 90-year-old individual is a healthy 90-year-old individual without significant memory or thinking deficits. So your brain is naturally changing with age. You lose about 5% of your overall brain size each 10 years after 40. So once you hit 40, every 10 years, you lose about 5% of your total brain volume. There's a thinning of the outer layer of the brain. Remember, we just talked about these different lobes. There's a thinning of the outer layer of the brain. The brain receives less blood flow overall as well. And there's changes in what are called neurotransmitters, basically these complicated chemicals in the brain that help the brain function the way it's supposed to. Those levels will change over the course of time. And so as the brain naturally ages, what tends to happen is that we start to experience and notice changes. So very common things that are consistent with what we call normal age-related cognitive changes. Difficulty learning or retaining new information. It seems like it's a little bit more challenging than it used to be to remember or learn things. Names, right? Coming up with the right names of folks we haven't seen in a while, family members who we haven't seen in a long time. Sometimes the name can kind of be there, but it takes us a little bit longer to get to. We're more distractible than we used to be. We may be in conversation, and in addition to names, there may be a word we're looking for. And instead of saying the word, we say, you know, whatchamacallit. And then there's 20, 30 seconds. And then all of a sudden, you know, we're able to remember. Feeling like we're thinking a little bit more slowly. Walking into a room, I don't remember why I'm here. I walk back out. Oh, yeah, that's right. I needed to get, you know, the bottle of water. All of those things are consistent with just normal aging. And they tend to continue to occur as we get older. Okay. So if we understand that there is brain aging that is happening across the entire lifespan, that we all experience some level of cognitive change that's associated with normal brain aging, then by default, there has to also be abnormal brain aging. So again, we just focused and talked about normal brain aging. Conversely, there has to be what is considered abnormal brain aging. And many of us are familiar with this abnormal brain aging because we've seen individuals who have undergone abnormal brain aging. We have met, taken care of, loved individuals who have developed things like Alzheimer's and dementia, which are abnormal brain aging. They are not part of normal aging, okay? So getting into kind of the meat of the discussion, if there's this idea of normal brain aging, this idea of abnormal brain aging, this idea of Alzheimer's, this idea of dementia, what exactly is Alzheimer's disease then? What is actually dementia? So when you hear the word Alzheimer's disease, I want you to think of one word in particular, and that word is protein. protein, protein, protein. It has nothing to do with the protein that you eat. So if you're looking forward to enjoying, the chicken dinner later or the hamburger after this presentation, you can still have that. That's perfectly fine. But it has to do with protein buildup and accumulation in the brain that's basically not supposed to be occurring, okay? And this has consequences to it. So what we're looking at here, we're looking at two pictures. You're looking at a picture of a brain on the left, which is from a healthy individual. You're looking at a picture of a brain on the right, which is from an individual who likely had Alzheimer's disease. You can see the picture on the left looks very different. So this is actually the front part of the brain on the left side. The back part of the brain is on the right. It's the same thing with the unhealthy brain. The front part of the brain is the left, back part of the brain is the right. And you can see the back part of the brain in particular in the unhealthy brain looks very different. It's much more shrunken. You see how deep some of these folds and grooves are compared to the picture on the left. But even the front part of the brain doesn't look quite normal either. Notice how in the healthy brain, the front part of the brain is nice and round and full. On the unhealthy brain, it's much more of kind of a sharp edge, so to speak. And so this, again, is a brain of an individual who very likely had Alzheimer's disease. But you may be asking yourself, well, Doc, you said Alzheimer's disease has to do with protein. I don't see protein on a picture anywhere here. What are we talking about? It has to do with what's going on underneath the surface, okay? So just to give you a sense of how densely packed your brain is, your brain has 86 billion neurons packed in it. So the 6 inches in between your ears, that brain that's occupying that space, there are 86 billion neurons sitting within the brain, okay? Your neurons are the workhorse basically for the brain. You have 100,000 miles of blood vessels in your brain. It's a tremendous structure when you think about it. There's so much packed inside. And what happens over time is that as these proteins build up and accumulate, of course, you don't see them on the big picture, but underneath the surface at a very, very small level under the microscope, we can actually start to see them. There are 2 proteins in particular that I want you to keep in mind. These proteins are called amyloid, and the other protein is called tau. Amyloid proteins, as they build up, they clump together and they form what are called plaques. We're familiar with the term plaque, right? Plaque in the teeth, plaque in the arteries, etc. Tau proteins, as they build up, they form what are called tangles. Tangles, like a tangle kind of set of wires, so to speak, okay? And what happens is that when these proteins continue to build up and continue to accumulate in the brain, they start to spread. And as they start to spread in the brain, you start to get more and more damage to neurons and other structures as well. So the amyloid protein, when it starts to spread around the temporal lobes, the bottom part of the frontal lobe, and then you can see it start to really take off. It starts to occupy space kind of all over. With the tau protein, it's actually a little bit different. Amyloid protein starts building up oftentimes a decade before tau actually starts to really accumulate. The tau protein will also start kind of in the temporal lobe, but it will stay in the temporal lobe and the frontal part of the brain a bit longer. This is why for individuals who have Alzheimer's disease, so often the first symptom is memory. I can't remember things. I can't remember my way home. I can't remember what I did at work. I can't remember what I ate yesterday. And it's because the tau protein is driving that memory problem. So the tau protein sitting around the memory part of the brain and the temporal lobes is really causing that issue. Many folks, again, who are familiar with someone who has Alzheimer's disease knows, though, that this is only the beginning. As things get more severe and as the tau protein spreads, other problems set in. All of a sudden now we're not able to cook. We, accidentally set fire in the kitchen. We can't drive because we're getting lost. We can't pay bills anymore because we don't know how to actually manage, finances. So as the tau continues to build up, we see really the decline and we see more and more dysfunction overall. So this is Alzheimer's disease. We're going to talk about dementia in a minute, but I want to leave this slide up to really emphasize and have you burn the image into your mind. This is Alzheimer's disease. When we say Alzheimer's disease, this this is specifically what we're talking about. We're talking about amyloid, we're talking about tau, we're talking about them being basically on a runaway train where they're building up in greater and greater amounts, causing more and more damage. Okay, so what are some of the signs and symptoms of Alzheimer's disease? I just mentioned memory loss. I want to go through a couple of others, though. So when we say memory loss associated with Alzheimer's disease, we're talking about memory loss that disrupts day-to-day life, right? I talked earlier about as part of normal age-related changes, we may have difficulty with a name, sometimes comes to us. We may forget why we walk into a room. But what I mean when I say disruptive symptoms, memory loss in terms of I missed a critical follow-up for the doctor to check on my prostate cancer because I just forgot it. I missed my granddaughter's first birthday party. I've missed 6 bills because I've forgotten about them, and now I owe $600 in penalty. That is significant memory loss that is disruptive of day-to-day life. That is what we're talking about when we say memory loss. But there are other things that you have to keep in mind as well. So difficulty with problem solving. Say you lifelong have been very good with the computer or the phone, whatever may have you, and all of a sudden you can't for the life of you figure out how to turn the computer on. You can't for the life of you figure out how to make a basic phone call. That is not normal. Doing familiar tasks. I've driven to my daughter's house 50 times probably over the course of the last year. And all of a sudden, I'm having difficulty now remembering actually how to get there. I got lost to a point where I had to call the police and they had to escort me home. That is not part of normal aging. Confusion with time and place. This is one that sometimes we overlook. Sometimes we even joke about. I think a good example of this is somebody shows up to the building on Thursday night at 11 o'clock at night because they think it's Sunday morning worship service, right? And we may even chuckle about that. Oh yeah, you know, so-and-so was here Thursday at 11 o'clock at night, but that's not part of normal age-related change, okay? That's abnormal. Difficulty with speaking or writing. Say lifelong, we've been very good with regards to reading. We've been very good with regards to our penmanship, our writing. And all of a sudden, we start composing messages that don't make a lot of sense. The grammar is wrong, or there's missing subjects, or the spelling is really off, or we're reading something and we don't really understand what we're reading. And it's something very simple, like an announcement in the bulletin. Those things are not part of normal aging. And then finally, one that we don't talk about a lot because I think there's stigma associated with it, but it's notable changes in mood or personality. So what do I mean by this? This oftentimes is one of the earliest things that we actually find when somebody has Alzheimer's disease, but it's almost always missed. So say you have somebody who has always been lifelong, very cheery, very positive, good attitude, no history of depression, no history of anxiety. And all of a sudden, around the age of 65, 68, they develop this crippling depression or this crippling anxiety. And it's not because somebody has passed away. It's not because of a major life event. It's just kind of out of nowhere they started to develop this. That oftentimes is the very beginning of Alzheimer's disease. It's the very earliest symptom. But the problem is that, again, we miss it. We say the person's having, you know, a late life crisis. We make excuses rather than really investigating what is it that is causing the problem and do we need to do some additional testing. And we'll talk about what happens with kind of some of these personality changes when they're basically left unchecked. Really, bottom line with all of these symptoms is you have to talk to somebody about them and you have to investigate them earlier as opposed to later. They're not going to go away if it's the cause. If Alzheimer's disease is driving them, they're not going to go away on their own, and they are very likely going to get worse. So let's look at, as we transition into talking about why it's important to have an early diagnosis, let's look at what early versus late looks like. So we're going to look at some pictures here, and I hope you'll be able to appreciate the differences in the pictures. Picture on the left, again, you're looking at an MRI of the brain. You're looking at somebody face on. Picture on the right, it's the same thing. It's an MRI of the brain looking at somebody face on, but the pictures look very different, right? The picture on the left, you see more of kind of the gray and the white material, which is the brain matter. On the right, you see much bigger of these kind of dark spaces and these grooves in between the brain matter, which basically has occurred because the brain has shrunken. So in early changes, somebody may forget what they saw on TV yesterday. They may have watched a show. You ask them, well, what did you watch? What was the plot? They don't really remember. By the time we get to advanced changes, we're forgetting who our grandchildren are. We no longer know who they are. Other things, again, this is a picture of an MRI on the left. You're looking from the top. You're looking down at the top of the brain. Again, picture on the right, same thing. You're looking at an MRI, but you're looking down at the top of the brain. I hope you can appreciate that if you look at the back part of the brain, it is drastically different compared to these two pictures. So early changes, I may have some difficulty finding my way home. I may have to call my daughter or my son, every once in a while trying to get home because I can't remember exactly how to get there. I miss a few turns. Advanced changes on the right, you can't see an object 2 feet in front of you. And when I say you can't see an object 2 feet in front of you, I mean literally if I held a pen 2 feet in front of your face, you would actually not be able to see it. I have patients who actually have this level of vision issue. Nothing wrong with their eyes, but the back part of the brain that's responsible for taking all that visual information in is no longer working appropriately. One more picture just to drive home the point. Again, picture on the left, early changes. You're looking at the top of the brain. Pictures on the right, advanced changes. Again, looking at the top of the brain. This time it's the opposite. You see the front part of the brain on the left compared to the drastically different front part of the brain on the right. And this one really drives home the idea of changes in personality and mood. Early changes, some mild changes in personality. That's kind of strange. Mom is doing that. That's not really her. Why is she, we'll just, it's probably nothing. We won't worry too much about it. Advanced changes, I lost $25,000 in a single week because of compulsive gambling. I have patients who have done this. All of these pictures are actually from my patients. This is actually the picture of one of my patients, what their brain looks like as they've gotten to very advanced changes. So what is the difference then between dementia and Alzheimer's? Hopefully you have held on to this idea of Alzheimer's being proteins, proteins, proteins. What do we actually mean when we're talking about dementia then? So when you hear the term dementia, I want you to think of one word, and that word is function. Function, 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 okay? Alzheimer's disease, protein, 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 protein. Dementia, function, function, function. Dementia just simply refers to, it is a condition where somebody has experienced enough thinking and memory changes to the point that they can no longer function independently. Okay, these can be changes in memory, these can be changes in personality and mood, these can be changes in language, speaking, et cetera, but things have gotten so bad that they can't live and function independently any longer. They need help. There are many different causes of dementia or types of dementia. All of them, with the exception of a few, actually have to do with a protein buildup. So Alzheimer's disease, which is a protein buildup in the brain of amyloid and tau, can cause dementia. Lewy body disease, which is actually also a buildup of protein in the brain, it's the alpha-synuclein protein specifically, different type of protein, can cause dementia. Frontotemporal disease, which again is a type of disease where you have a buildup of proteins in the brain, can cause dementia, okay? Vascular disease, this is not actually a protein buildup. This is the blood vessels in the brain becoming less healthy. That can also cause dementia. So you see how dementia is kind of this big umbrella. It covers a lot of different things. It covers things like Alzheimer's disease, Lewy body disease, frontotemporal disease, as well as vascular disease, okay? So hopefully, as you think about these two terms, you understand they're separate. They're not the same thing, okay? What typically happens is that if somebody develops Alzheimer's disease or develops Lewy body disease or develops vascular problems in the brain, it typically leads to dementia. But it's not the other way around. Dementia doesn't lead to Alzheimer's disease. Dementia doesn't lead to Lewy body disease. It's a one-way path where you develop the problem and then it can lead to an issue. Okay? So how do we actually diagnose conditions like Alzheimer's disease? If it's so important to have an early diagnosis, what do you actually need to do to get a diagnosis? There are a number of things that if you go to a doctor, a neurologist, geriatric specialist, a geriatric psychiatrist, there are a number of things that they essentially will recommend that you do. One is a neurological exam. A neurological exam is essentially the doctor will spend time sitting, talking with you, asking you questions about your symptoms. They'll do an examination to check things like your balance, your strength, et cetera, et cetera. The doctor then may also recommend or even do neuropsychological testing. This is typically pen and paper testing, where you do things like math, you try to remember a list of words, you try to draw complicated pictures, and all of this gets scored. The doctor will then recommend that you do certain blood tests and have certain pictures of the brain taken. We tend to prefer pictures like an MRI because they give the most information. We'll check the blood for things like a vitamin deficiency or a thyroid issue, other things that can mimic oftentimes conditions like Alzheimer's. And then the doctor may actually order some additional special tests, which we'll talk about in just a minute. So why is it important to diagnose early? Well, we've really focused and emphasized a lot of kind of the dreaded conditions, I would say, that cause dementia, but there are actually a number of treatable causes of dementia. There are actually a number of causes of dementia that there are cures for. There are some, as I mentioned, vitamin deficiencies that can mimic Alzheimer's disease, that if you just simply replete and replenish the vitamin, the symptoms actually will go away. We understand medications are more effective when somebody's dementia is less severe. We're going to talk about that in a bit. And Kim Scott is going to go into some of the newer therapies and why it's so important that we start them early if we can. We know, again, that the non-drug intervention, so even if you're not taking a medication, doing things like exercising more, eating right, et cetera, these actually are more effective when dementia severity is less so. There's more time available for planning. So if you take away very few things from this talk, I hope the other thing that you take away from this talk is that you have got to think about planning. You have got to think about the future. What happens very frequently, especially when there's some level of memory or thinking change, is that nobody thinks to a point where an individual may actually have difficulty making their own decisions, and then it's catastrophic because you have arguments between child one and child two about what mom really would have wanted. You know, it becomes an absolute disaster. And it's because nobody sat down and thought about, you know, what if we get to a point where mom is having more problems? What if we get to a point where dad can no longer make these decisions? So you have to think about some of those things early. Knowing that there is maybe an issue early gives you time to plan also for more activities that you enjoy. We spend a lot of time each and every day doing things we're not the most enthusiastic about. But if you know that you have a bit of a cognitive decline going on, you may reprioritize some things. Disability. Some folks actually are still working while they develop these notable changes. And if you have a diagnosis early, you actually can apply for and oftentimes receive disability that can be substantially beneficial over the course of time, and then improving safety as well. So I mentioned that there are identifiable and treatable causes of dementia. These are just a few of them. There are actually many more. The vitamin I've been referring to over and over is actually vitamin B12. If you have a notable vitamin B12 deficiency, it can actually look like Alzheimer's. It can look like Alzheimer's causing a dementia. And the solution is just to basically replete the B12, give somebody B12. Thyroid issues, having uncontrolled thyroid issues can make it look like you actually have a dementia because of something like Alzheimer's disease. Very rarely, things like tumor will be a cause, uncontrolled diabetes. One of the ones I want you to really think about actually and try to remember is medications. If you look at the research, if you look at the data, the number of medications that we end up on as we grow older is staggering. What typically happens is that there's never anybody who's looking at the list of medications in totality and trying to figure out what do you really need and what can we get rid of. What we usually do is that medicines are just added on. So you're on your list of 5 or 6. And then let's say you have a bad year. You go to the hospital twice. They add a couple of more each time. You know, you have this respiratory issue that you can't get rid of. And so you end up on a cough medicine. You start having a bit of an upset stomach because you've been coughing so much and you've been in the hospital. Now you're on an acid reflux medicine. So you go from 5 medicines over the course of a year to something like 10. And then all of a sudden everything settles down. But what doesn't happen? What doesn't happen is you don't come off of the medicines you don't need any longer. You just stay on those 10 medicines forever and ever because nobody's asking, do you really need to be on this? So I will tell you, just to be honest, the way to make sure you are on really the medicines that you only need to be on, it's going to have to actually take some effort on your part in that you have to approach the doctor each time you're in your annual wellness visit or each time you're having kind of an encounter and go through your medications at length and ask them, why am I taking this? How long have I been taking this? And do I really need to be on it? It can take a substantial amount of time. Sometimes you may need to do this over 3 to 4 visits. But I can tell you, if you're not doing this, you're going to remain likely on medications that aren't benefiting you. And many of them may actually be interacting together that may be causing a problem, particularly with regards to cognition. So I can't stress the medication part enough just because we see it so often. Okay, couple more things before I hand things over to Kim Scott to talk about some of the newest advancements in therapies. I want to show you 2 pictures here. These are pictures actually from the same brain. So this is one individual, but the pictures are 1 year apart, okay? And this gets into a little bit of the special test I was talking about. So I remember when we said Alzheimer's disease, we said protein, 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 protein. The picture you are looking at here on the left is actually a picture of amyloid protein in the brain. That is actually all of the red. So all of the red that you see here within the brain, these are the actual amyloid proteins of Alzheimer's that have built up. Again, the picture on the right, this is the same individual. This is the same person getting their brain scanned, but this is after 1 year of receiving a new therapy. You can see the dramatic reduction where all of the red is almost gone. You have just a spot here and there, but you have basically removed the amyloid protein from the brain. If you've been following the news, you likely have seen that there are new treatments for Alzheimer's disease. This is what they can do. So specifically the lecanemab medicine, which was FDA approved not too long ago, this is actually a brain of an individual pre-lecanemab treatment and after lecanemab treatment. So we have new powerful tools to be able to start to address some of these proteins that build up in Alzheimer's disease. They are not yet curative. I want to stress that they are not yet curative, but they can slow things down substantially. Okay. Just the last few things, again, really emphasizing early diagnosis. This is just a graph showing that naturally what happens is that things will get worse, but the earlier you diagnose and the earlier you treat, potentially the sooner you can kind of level off how severe symptoms are. Unchecked, allowing things to continue on though, the severity gets worse and worse. And even if you treat, we can't yet bring people back. The medicines don't yet return people to a prior state. They slow progression more than anything else. So the idea is identify very early, treat, and prevent the downstream bad consequences. You can think of it in many ways like cancer. God forbid, but if you were to go to the doctor and the doctor were to say you had cancer, would you want to start treating the cancer at stage 1 or would you want to start treating the cancer at stage 4? It's very simple, right? You would want to start treating the cancer at stage 1 because having an earlier diagnosis and treating earlier means you're going to have a better outcome as opposed to if you start treating very late in the game. I mentioned that outside of medication, if we do things like lifestyle engagement, it actually helps more when we start these things early, and having an early diagnosis allows us to start these things early. This is a graph from a research study where they were looking at individuals who were diagnosed early on with a problem compared to those who were diagnosed later on. And these people were basically given a lifestyle intervention. So they were told, you know, we want you to, they actually were just walking. They were walking basically a mile each time, 3 times a week, or not walking. And you can see there's 2 lines here. There's a darker black line and there's kind of a dotted line. And you see they're separate. The darker black line is kind of above the darker, the dotted line. What this is showing is that the people who started doing exercise with an early diagnosis and were exercising more than 3 times a week, they remain dementia-free for longer than the people basically who weren't doing exercise and who were basically diagnosed later on. So even introducing something like good diet, good nutrition, if you introduce it earlier when problems are less severe, you get more of a benefit in the long run. This is probably one of the more striking pieces of kind of data that I've come across recently. This is looking actually at household wealth. So this is a study where they tried to understand what happens to household wealth over the course of somebody who has Alzheimer's disease. So if you're a family taking care of an individual who has Alzheimer's disease, what is the natural course of the financial wealth and financial health of the household? In this study, they actually compared different racial and ethnic groups. So they looked at white households compared to Black households. What they found was that in Black households, individuals who did not have dementia, so Black households taking care of individuals without dementia, that's the dark black kind of dotted line, you can see it's kind of level. So it goes down a little bit, but then it kind of levels off. It's pretty stable. If you were taking care of somebody who has dementia, specifically somebody who has dementia due to Alzheimer's disease in this study, you can see it's a precipitous, continuous decline over the course of time. So already starting out, these households had about $40,000 in wealth. They lost 90% of their household wealth over the course of caring for a loved one with Alzheimer's disease. Many of us in this country are familiar with the idea of intergenerational wealth, right? That's typically how in the US wealth is built. You save a certain amount, you pass it on to your kids, they pass it on to their grandkids, and it's a multiplying effect where by the time you get to the fourth or fifth generation, that's how folks accumulate property and other things as well. If you're losing 90% of your household wealth over the course of caring for a loved one with dementia, that is money and wealth that is not going to your kids. That is money and wealth not going to your grandkids. It is reducing your ability to build intergenerational wealth and leave something behind for the generations beyond you. And again, this can be addressed in part through early diagnosis, understanding there's a problem, intervening with therapy. You can prevent basically the escalating need for care. Many of us, again, who are familiar with folks who have Alzheimer's know the care demands continue to get greater and greater and greater as the disease progresses. If you don't stop the progression of the disease, you spend more time, more money, more effort into the care. More time to plan for activities. Again, if you know there is an issue, you can start to rearrange priorities around really what brings you the most value, what brings you the most quality of life. And then improving safety. What we oftentimes see as well is that as we get older, our home environment sometimes can be, not the greatest, I'll say, with regards to safety. So we oftentimes have a little bit of clutter. There are other things around that really aren't the best thing for us. We know that folks who have cognitive impairment, oftentimes they may develop some physical issues as well, or even because of the cognitive impairment, they're just more prone to accidents. And so if you know that there's a problem earlier on, you can start to address some of the issues. You can start to clean up some of the clutter. You can start to implement things in the kitchen where, we're not burning down, essentially, we're not burning the kitchen down because we're leaving the stove on. A lot of these things are easily preventable, but they're more easily preventable when problems are early on. Again, what we see too often is that people come in and things have been going on and progressing for a substantial amount of time, but something finally catastrophic happens at home, and then all of a sudden there's awareness brought to the problem. There's a fall with a hip fracture. Somebody burns down the kitchen. Somebody is scammed out of $40,000 because financially they've been kind of, vulnerable for a period of time because of their cognition. It's easier to implement safety and support mechanisms at home when you have less impairment than it is when things are more significant. Just to leave you with a couple of thoughts on, we've been talking a lot about Alzheimer's disease, dementia early diagnosis. Is there something you can do? Is there something you can do starting today that will actually improve your health? And the answer is absolutely so. There are 6 things that you can start doing today, literally today, that will actually improve your brain health and help to reduce your risk of developing something like Alzheimer's and dementia. I'm going to start actually with staying active. Physical activity is the single most important thing that you can do for your brain health. I'm going to say that again. Physical activity is the single most important thing that you can do for your brain health. Getting somewhere around 150 minutes of aerobic exercise each week will help keep your cardiovascular system and your cerebrovascular system healthy and help to reduce your risk of Alzheimer's disease and dementia. We have substantial evidence to support this. There are repeated research studies that have been done that show being physically active is inherently linked to a lower risk of dementia, a lower risk of Alzheimer's. Other things that are important: staying socially connected. Loneliness is one of the greatest, I would call it a pandemic in and of itself among our older individuals. Loneliness is critically important to try to avoid. And so staying socially connected with other individuals is really critical for your brain health. Managing stress, trying to eat a brain healthy diet. What I mean by a brain healthy diet, most folks at this point try to follow somewhat of kind of a Mediterranean diet, meaning more greens, more fruits, more vegetables, more of kind of the fish and chicken, less of things like the pork and the processed food and the sweets. Trying to maintain a diet like that also is a very strong recommendation and has a lot of evidence behind it in terms of keeping your brain healthy. Quality sleep. If you are not sleeping well, and I'm going to be painstakingly, brutally honest about this. If you are not sleeping well and you have not been sleeping well for any amount of time, you need to go to talk to somebody. You need to go and figure out why it is that you are not sleeping well. A lot of times it's just due to poor bedtime habits. Sometimes it's due to other medical conditions. It can be due to things like sleep apnea, other conditions that we have going on. You not sleeping well, however, is robbing your brain of its ability to clean itself out. So at night, when you enter into the deepest stages of sleep, your brain actually has its own garbage man collection system. So your brain will send out basically the garbage collectors and it will clean itself up. It will clean itself up of some of the amyloid and the tau protein that we talked about. But if you're not sleeping, if you're not getting restorative sleep, you're taking away your brain's ability to do that. So again, if you are not sleeping well, no matter how long you have not been sleeping well for, you need to go to talk to somebody and try to figure out why and how you can get better sleep. And then finally, meaning and purpose. We all need to feel fulfilled in this life. We all need to find meaning and purpose, and it's critical we maintain that throughout our years. So just finally, some take-home points. Brain aging, it happens. Each and every one of us, from the day we are born until the day we pass away, experience changes to the brain. As our brain ages, we can sometimes develop diseases and problems that affect our thinking and memory. Just like we can develop diseases and problems in other parts of the body, the brain is not immune to this. There are a lot of different tests to help us understand why somebody has developed problems with thinking and memory. And we have to do these tests and we have to know early. Waiting and expecting things just to go away or not get worse is not the right approach. You're going to be disappointed every single time. If you know somebody who is experiencing changes or you have noticed things yourself, you cannot sit and wait. You have to go and see the doc and talk about it, especially given what we've talked about in terms of many things that can be reversible and some of the newer medicines that we now have available for actual conditions like Alzheimer's, where we can't yet fully reverse, but we can slow things down substantially and make a difference. Truly appreciate your time and attention. I hope this has been informative. I'm happy to share any information through kind of distributed materials subsequent to the presentation, and happy to answer any and all questions that folks may have. Thank you again.
Thank you so much for that informative presentation. We did have a couple questions. One of them is dementia or Alzheimer hereditary or genetic?
Sure. So what do we know about dementia and Alzheimer's and kind of genetic risks? So what we know currently is that it's very complicated. It's very complicated. The assumption that many of us make is that, well, if mom had it and grandma had it, that means I'm going to get it. That is not true. If you have a first-degree relative who has Alzheimer's or has dementia or has one of the other conditions we talked about, with the exception of maybe vascular disease of the brain. If you have a first-degree relative who has one of these conditions, it does increase your risk of developing it. That is absolutely true. So if you have a first-degree relative, if mom had it, mom had Alzheimer's, you do have a higher risk of developing Alzheimer's. But again, it's complex. 60% of risk, or 50 to 60% of risk of actually developing dementia is modifiable, meaning it has nothing to do with your genetic risk factor. It's all of the lifestyle things we were talking about. So even if you have a first-degree family member who has it and you have a slightly higher genetic risk, you can offset that genetic risk by eating right, exercising, making sure you're sleeping well. You can do a lot of things to bring your risk down. It's the same thing with other conditions, right? If you have a very strong history, family history of something like high cholesterol, something like heart disease, you have a greater genetic risk for these conditions, but you can reduce your risk by exercising, eating right, doing all of the things that you need to do to keep yourself healthy. So yes, there's a genetic component. No, it is not as simple as if mom or dad had it or grandma has it, that means I'm going to get it. That is absolutely not the truth.
Okay. The second question was, can you address the eligibility of clinical trials and where to go for support? An example would be adult daycare, et cetera.
Yeah, so in terms of eligibility for clinical trials, so there's kind of two-part question. So eligibility for clinical trials, there has been a lot more awareness that has been brought to eligibility criteria, particularly restrictive eligibility criteria. So historically, what has happened is that in clinical trials are very, very rigorous and very, very strict. They want to know and they want to have essentially kind of very close grasp on all of the different things in terms of the research trial. And it's important, right? If you are giving somebody a medicine, you want to know whether or not it works. You want to know if it's specifically the medicine that's causing them to improve or not. You don't want them to be improving because of a whole bunch of other things that you're not measuring. So eligibility for clinical trial, every clinical trial will have the eligibility criteria laid out. You can go to a website, it's called clinicaltrials.gov, clinicaltrials.gov, G-O-V. On that website, you can actually look up every NIH-funded clinical trial for Alzheimer's disease, as well as other conditions, and you can see all of the eligibility criteria laid out. We are making a big push in the scientific community to make eligibility criteria less restrictive so that we can be more inclusive. One of the big issues with regards to Alzheimer's disease and dementia has been restrictive eligibility criteria, specifically eliminating and not having folks who have multiple medical kind of comorbidities participate. So if you have really high blood pressure, high cholesterol, diabetes, other things going on, a lot of times the research trials have not allowed these people to participate, but we're pushing past that to try to better understand really how to develop more effective medications. And then where to go for support. So this is a great question as well. I'm going to give you a website that I want you to look at. It's 6 letters. It's A as in apple, L as in Larry, Z as in zebra, .o, R as in Robert, G as in Geary, ALZ.org. That is the Alzheimer's Association's official website. On that website, there is a tremendous amount of information with regards to support. There is caregiver support on that website, as detailed as just how to deal with the day-to-day issues, things like incontinence, feeding, et cetera, et cetera. There is legal support. There is financial support. There is a 24/7-hour helpline actually on that website where you can literally call. You can call New Year's Eve at 1:30 in the morning and you will actually speak to somebody. It is literally 24/7, 365. It never goes off, and you will always speak to a human being on the other line when you call them. So that is probably one of my favorite resources, is to go on the Alzheimer's Association website and look at a lot of the information they have available there.
So another question is HSV1 a contributor to a decline in mental function?
Yeah, so really interesting question. So HSV standing for herpes simplex virus. So what do we know about viral infections and changes in basically brain health? So HSV is a particular virus which has an interesting kind of relationship with regards to brain health. And it's because of where HSV can cause damage in the brain. So if you remember what I said earlier about there are different parts of the brain, let me see if I can find a picture really quickly. But one of the regions I mentioned in the brain are called the temporal lobes, right? So in this picture, this structure here, the temporal lobe, you have one on either side, the middle kind of inside part of the temporal lobes, you can actually have HSV cause significant damage. And this area is around the hippocampus, actually. So you can have, it doesn't happen tremendously commonly, but it's not super rare. You can have HSV actually cause damage and scarring in the temporal lobe near the hippocampus. When this happens, you can actually develop notable memory impairment and memory problems over the course of time. You really need an MRI as well as some more detailed testing to be able to confirm this. Most people who have been exposed to HSV or have outbreaks, things like that, you don't have, HSV actually causing damage to the temporal lobe, but it can happen in more rare instances. That's a great question for whoever asked that.
Are there any more questions? I don't have anything else in the
You have a hand up, Reverend William Randolph.
Yes, I'm sorry. Good morning to everyone. My question, I heard the website of the Alzheimer's, can you repeat the website for the Alzheimer's?
Yes. Yeah, and I can put it in the chat also.
In the chat.
So the website is it's just 6 letters. Oh, Kim beat me to it. Thanks, Kim. It's just 6 letters. It's A as in apple, L as in Larry, Z as in zebra, dot O, R as in Robert, G as in Geary, ALZ dot ORG.
Thank you very much, Mr. Windom. That is very helpful.
Great.
Pam, you have another hand.
Gwendolyn?
Yes. Good morning. I have a question. Can you put the chart up again about the various different tests that you want to test for? I wanted to take a picture of that.
Sure.
Mm-hmm. Okay. And the other thing, I'm going to take this picture. The other thing I wanted to say to you, having gone to a neurologist and taking my husband to a neurologist, and I don't know, as being an African American, if we get the same kind of treatment. For instance, there were some telltale signs that my husband and I were talking about, but when we got to the neurologist in Berkeley, California, he gave him a brief, I think it was like 20 questions, and said, "Oh, there's nothing wrong with him."
Sure.
And
Sure.
so that happens. The other thing is not being able to, you talked about the clinical trials. Some went to one doctor and they had talked about, would you like to be involved in it? And I said, yes. There was never a follow-up. And what I heard you saying was, and here's what you said, I heard what you said, and here's what I heard, that certain maybe groups of people cannot be responsible enough to follow through on the criteria that is expected. In other words, the reporting requirements, the dates that you have to come in, or those kind of things. Because I find a lot of times going to the same doctors, African Americans aren't given the opportunity. They might not have any of those diseases that you mentioned, but they're not given the opportunity. They're not asked.
Absolutely. Yeah, I think this is a fantastic question because it brings up really a critical point about our healthcare system. And I will be frank with you all this morning. Our healthcare system is marred by the fact that depending on the color of your skin and how much money is in your pocket, you get treated differently. That is absolutely the truth. That is not shocking information, I think, to many of us, especially for us as African American individuals. We know historically what has happened in this country with regards to medical treatment and medical resources. So I tell everybody, whenever you go in front of a medical care provider, your role, what you have to do is you must advocate. If you don't like what you're hearing, if you're not getting the answers that you feel like you deserve, you have got to become the squeaky wheel, so to speak, until you get the answers you deserve. And that may even mean if you see a provider and you just don't like what they're saying and they're not providing you opportunity, they're not providing you information, you leave that provider. You demand that basically your other care providers refer you to another person. We, again, from a medical kind of community standpoint, the level of advocacy that is needed is substantial. It really, truly is. And just to play devil's advocate just a bit, unfortunately, the provider you're seeing, I think many providers, they don't do it by intention, but our medical system has become one in which it prioritizes efficiency and speed over patient care. So the doctor you're seeing, I don't work in primary care, but I working through school and things like that, have a lot of exposure. Your primary care doctor, for example, sees anywhere from 30 to 50 people in a single day. And you imagine how complicated the medical histories can be. That is only so much time that can be spent with every individual. Otherwise, people are not getting care, right? So there's a limited amount of time always. And that's where the advocacy comes in. You have to demand, even if it means repeated visits, you have to demand the information and the care that you deserve until you're able to receive it. The clinical trials aspect of things, you absolutely hit the nail on the head, in that there is a huge problem with referral bias, meaning providers themselves are not referring individuals from diverse groups to clinical trials at the rate that they should. This is actually an area of interest of my own, and myself and a number of other individuals are working towards trying to eliminate some of these inequities, but we just can't do it alone. We need folks who are receiving the care to also advocate. And I mean, part of the visit may even be you informing the doctor of what they need to know. There are a lot of providers, they don't even realize we actually have blood tests. We have imaging tests to detect Alzheimer's disease. You may be educating them more than actually they're educating you. And that's okay. We all need to actually try to get better in this process. And again, that person in front of you, the medical care provider, they're still going to be the conduit for you to be able to access the services and things that you need. So you do have to somehow work through them or somebody else.
Well, and I thank you for your answer, because I don't want to belabor this, but I know that sometimes I don't feel that way, but sometimes people are very threatened by doctors, or they feel inadequate, that they can't speak for themselves, or they don't know how to. The doctor says this, and this is just what you do. And I wanted to say to you that I went to Eden Medical Center out in Castro Valley, and I had some really bad experiences for my husband, and I continued to talk. And I'll tell you, I got apologies. I mean, and things begin to change. I mean, we're not there yet, but I'm just saying, having a neurologist or a whatever the professional I'm trying to say, tell you things like, well, this doesn't look good, and this is what they told me about my husband when we first came in. So I'm just really concerned about people my age, people that are older, when we go to the hospital or to the doctor, that we don't have people to advocate for us. Sure. Because they will give you all that medication that you were talking about. Nobody takes care of you unless someone goes with you. So I just wanted to say that, because I'm right in the middle of that. My husband had a stroke, and he went from it doesn't look good to now he's smiling, even though and here's what I educated the doctor on. I said, I'm a practicing Christian. And I said, I believe in hope
Mhm.
and I believe in God.
Absolutely.
And that's all we've ever had as people of color or Black people. But thank you so very much.
Thank
Dr.
you.
Windom, we had another question regarding the implications of long COVID on dementia.
Yeah, so this is a really kind of new area of research. And the short answer is we don't fully understand. We don't fully know. We know COVID. So if you remember back to COVID, you remember back to kind of the heyday, I'll call it, of COVID. We understood and we remember that many people who had COVID were developing neurological symptoms as well, right? People were having strokes, people were having seizures, et cetera. So we know COVID can infiltrate the nervous system, but what does long COVID actually do from a standpoint of cognition, from a standpoint of memory, from a standpoint of risk for developing something like dementia? We just don't know. And part of it is, you think about it, it's 2024. COVID only happened 4 years ago. We don't know because we don't have enough data to really fully understand folks who have long COVID, what actually happens to the brain over the course of time. So a really critical area of study. We just wish we had more answers, and the answers will only come with time, unfortunately.
Okay, and then Nurse Kim had her hand up, so we want to get to her before we do her presentation.
Yeah, phenomenal presentation, Dr. Windom. This is just a comment. Actually, my partner's here listening as well, and he's a provider, but also advocating for yourself and preparing for your visits is to write down all of the questions that you have. And before you leave, make sure all of those questions are answered to a level that you understand. So that's a way to prepare, because we know we get anxious, we're in the office and we forget all of the things. So really, just as a way to prepare, get what you need when you go to the doctor, is to really write down those questions. And, as Dr. Windom was saying, bring someone along with you that can also advocate for you. And there are some organizations that will try to carve out an appointment type that's long enough. I work for Alameda Health Systems, and we are doing a pilot where it's like the chief complaint. So we're making sure that the patient is actually writing down, what are the main things that I want my provider to address in this visit?
Thank you. I think that's excellent information. I know I prepare my information. Sometimes I send it to the doctor ahead of time so that they'll have that information when I get into the office. So we can go boom, boom, boom. Because we know they're, like Dr. Windom said, they only have a limited amount of time because they see so many patients in a given day. Okay, so since we're on that, thank you so much, Dr. Windom. We'd like to thank you. What an excellent presentation. We want to get on to our next half of the presentation. Let me tell you a little bit about Nurse Kim. Kimberly Scott is a nurse leader from the San Francisco Bay Area. She holds a master's degree in nursing administration and business administration. With over 20 years of healthcare experience, Kim has established herself as a nursing advocate, author, speaker, coach, motivator, and connector. Kim is an equity, inclusion, diversity, and belonging champion. She has a passion for mentoring and loves to serve and speak about building community. Kim refers to the community as common unity. Kim is a past president of the Bay Area Black Nurses Association, Incorporated, and past board of director member of the National Black Nurses Association, Inc., NBNA. She is the immediate past national chair of the NBNA Collaborative Mentorship Program. Kim has made developing the next generation of Black nurses her business. She has also served as conference chair of the Florence Shroud Black History Month Nursing Conference Series for nearly a decade. This conference addresses increasing diversity of the nursing workforce and combating health disparities. Kim's current role is Ambulatory Care Director of Nursing for Federally Qualified Health Center, FQHC, in the East Bay. Kim is co-author of an anthology, The Diaries of a Resilient Black Nurse. She is also executive producer of her yet-to-be-released show on Hip Hop TV, Health Diary Conversations with Nurse Kim J. She serves on the African American Wellness Project Advisory Board, as well as a community advisory consultant for the UCSF Alzheimer's Association and the National Black Nurses Association AHEAD project to increase education, awareness, and participation in clinical trials among African Americans for dementia. Kim's proudest role is mother of her daughter, Sydney, an aspiring young lady. Thank you so much, Nurse Kim, for being with us this morning. So you can, take it away.
Thank you, Pamela, so much for the introduction. You know, I want to thank you for the opportunity to share with you all. I'm very familiar with Allen Temple as being a community educator as well as a disciple. I come to you with greetings from Bishop Keith L. Clark from Word, a family of churches, where I'm also an elder there. I'm here to talk about a clinical trial and the importance of collaboration among universities, organizations, and of course, professional organizations of nurses. I want to tell you what my personal why is. My paternal great-grandmother passed of Alzheimer's, and my paternal grandmother had dementia. And also as a nurse, I consider it an extreme privilege and honor to be a nurse, that I have the privilege to be with people in their most vulnerable states, to also be blessed with the capacity of human kindness, to be able to care for those as if they were my family members. One of the things that I tell new nurses or students who are considering nursing is that you have to have the capacity to be able to care for someone as if they were your family as a nurse. Mm-hmm. So over the last several years, I have functioned as a consultant representing the National Black Nurses Association. And over the last year, I've worked very closely with Dr. Windom and other colleagues from UCSF and the Alzheimer's Association. I want to point out, I have closed caption here. So with the diversity hat, for those who may be hard of hearing or have a difficulty understanding, we also have the closed caption there as well. So just talking about the journey that I have experienced with UCSF as well as the Alzheimer's Association has been an extreme pleasure. As you heard, my background is mostly nursing leadership and as an administrator. And my heart has always been in the community of basically bringing the information to the community, bringing the information to my people where they can understand it. Right? So to think about icons, I was like I've had the privilege to be the Harriet Tubman of nurses, to bring that information back to the people where they can use it, they can understand it, and apply it to their lives, to not only improve their lives, but to improve the lives of the communities and the people that they love and can influence. So a little background about the National Black Nurses Association. The National Black Nurses Association was established in 1971, and we represent over 200,000 African-American registered nurses, licensed vocational nurses, nursing students, retired nurses from the U.S., Eastern Caribbean, and Africa. Our local chapter, which was established in 1969, is the Bay Area Black Association. And actually, we have a national conference that will be in San Francisco after 20 years, our 53rd Annual Institute and Conference in San Francisco, July 23rd through the 28th. And then the Alzheimer's Association, which I learned several years ago, provides so many resources and information, as Dr. Windom shared, the alz.org, so much information to help us to learn about the disease, as well as resources to help caregivers and those who are dealing with dementia and different types of Alzheimer's. But of course, they lead the way in Alzheimer's and all dementia by moving global research forward, pushing to decrease risk and identifying early and making early diagnosis and making the best use of quality support. So before we talk about trials, we must talk about the elephant in the room, right? We must acknowledge the past and the harm, exploitation of Black people, of poor people, of people who just don't have rights. In the book here, The Medical Apartheid, I suggest if you haven't read it to please read it. You will be very upset after reading it, but it's important for us to understand what has happened to us as a people and acknowledge the history so that we can do better in the future, right? So while we acknowledge what has happened to us, we have to say, how can we be part of the solution? We can function in fear, but that doesn't get us far, right? So when we understand the atrocities, the harm that has happened to our people, it can fuel us to then say, how do we want our present and our future generation to be, right? We have to understand that in order to have solutions, we have to be part of that solution. And so as I talk about the clinical trials and how important it is for us to create treatments that are for us, we have to be part of the solution, part of that. So acknowledging abuse and encouraging African Americans to participate in research are compatible goals. There are several different research and the exploitation of our people that's rooted in its complex history of medical exploitation, discrimination, and systemic inequities. And we know about is the Tuskegee experiment. Right. And this was a syphilis study that spanned between 1932 and 1972. And one of the most infamous examples where Black men with syphilis were deliberately left untreated without their informed consent to study the natural progression of the disease. And so this is the one that we know about there, but there are several different just horrific examples of where our people were experimented on without consent. There is the Sims and surgery. This is a example and a horrific example. You can find out more, read more about it in Medical Apartheid, of experimentation on during the antebellum period of doing gynecological procedures without administering anesthesia on women. This is just, it's very horrific, where people would just experiment on mostly enslaved people or people who just didn't have rights. We also know about Henrietta Lacks. Yeah. Henrietta Lacks was a 31-year-old woman who she passed away from a very aggressive form of cervical cancer. But researchers at Johns Hopkins took her cells without the consent of course, of her or her family, and used her cells to really improve other conditions and the study of cancer. We now know that her family has received the benefits of the use of her cells. And so we're glad about that. And then the other example was Eugene Signer. And this is where they exposed poor and Black cancer patients to life-threatening levels of radiation without their consent. And so this was a Pentagon study. So here are all the examples of maybe why people may question, why should I be involved in a clinical trial? And just to pause there, it's important for us to understand that there are people who look like us, who are researchers, who have made experiments or who have invented cures and inventions. When I think about Black History Month, there's so many of our people who have created things that have increased the advancement of life in the medical field and just as far as our everyday in and day life that we have not heard about. But I want to highlight some of the researchers that look like this and have made incredible contributions to the improvement of disease and cures and advancements and medical treatments. The first one is Dr. Patricia Bath. She's the first African-American doctor to receive a patent for a medical invention. In her ophthalmology training at NYC, she did a study to examine why there were much or more blindness in the Harlem Clinic compared to those that were at Columbia. She invented the laser phaco probe for cataracts. Real. Next, we have Solomon Carter Fuller, who worked under Alois Alzheimer in 1912 and published the first comprehensive review of Alzheimer's disease at that time. He translated Alois Alzheimer's original case into English for the first time and also described the 9th recorded case of the disease. Next, there is Dr. Jane Cook Wright, who worked with her father. She was one of the earliest African-American graduates of Harvard Medicine at Cancer Research Foundation in Harlem, and she created new ways of testing drug effects on cancer cells using patient tissue versus rats. Her work helped chemotherapy become mainstay of treatment instead of end resort palliative care. And then her father, Lewis Wright, he's an African-American surgeon who introduced intradermal vaccination for smallpox while in the Army in World War I. Just a reminder, everyone, if you could please mute. Thank you so much. So what is research? Research basically is a process of collecting information to answer questions. There could be surveys that are collected to get understand people's views or get their information. There's a lot of research that tries to find ways to cure health problems. And then clinical trials are examples of research in action. I can recall participating in a clinical trial for a condition I had, just to understand, when you have certain conditions, it's like, how could we improve our current medications or treatments? And it was a very informative process, and we talked about the criteria for it, which you could also learn at the Alzheimer's website, but to understand what is going to happen to you as someone who's involved in a clinical trial. Also understand what could also disqualify or make you not eligible for a clinical trial, but to just go through that process was very informative. And also, I want to be a part of creating a solution or making treatment or curing a disease. We've come a long way. And here are some of the examples that seem kind of ludicrous. And then we think about what we have now. So just imagine smoking was actually viewed as a cure for asthma. Now we know through research and information. Also for the treatment of tuberculosis, now we have major advancements in tuberculosis and the treatment. And then also radiation treatment of cancer have had great and huge advancements and has been a major treatment for cancers. So what are clinical trials? Clinical trials are ways to make life better. We can look at new medications and see how they work. Are they safe for many people? So some of the examples of clinical trials that have happened are testing to see if aspirin reduces heart attacks. Also testing if insulin reduces diabetes. We could think about the treatment of diabetes. If there's anyone who has diabetes, we can see now that instead of poking yourself every day, now there's the continuous glucose monitoring. And so those are examples of the advances of medicine that make life better for people who have conditions and have better monitoring and treatment of their condition. Another example for heart disease is now that stents can be put in place that have medications on them. So they're drug-eluting stents over time. So there's been so many advancements, and we're so grateful to the improvements in medicine and treatment of disease as a result of research. So why is it important to participate in research? And more specifically, as we talk about Alzheimer's disease, there's some statistics that I really want to share that really are staggering. So African Americans are 2 times more likely to develop dementia. It's the 6th leading cause of death. 1 in 7 African Americans age 45 plus have subjective cognitive decline. So for short is SCD. And this is a self-reported memory problems that have gotten worse over the past year. So when I think about my life and how busy so many of us are and distracted, our memory is really depleting. As Dr. Windom had mentioned, there are simple things that we can do to start to improve our cognition, for us to take supplements, to move our bodies that can help reduce our slow decline of our memory health, but just knowing what we should do. So stressful life experiences, they age our lives 4 years. And especially as African Americans, we know we just have a sense of chronic stress already from our generational, traumas. So really managing our stress can be very influential and very beneficial for the improvement of our health. And one of the major things about dementia and Alzheimer's is the caregiver. There's over 2 million African American caregivers, and to understand the physical, psychological, mental, emotional burden on caregivers is it's astronomical. So there's so many people who are working full-time, taking care of their children, as well as maybe taking care of an aging parent or a loved one that has critically impacted their life. It is noted that 22 hours a week among African American caregivers is contributing to caregiving. So that can be on top of a full-time job. So the burden of this disease among our people is huge. And while we represent only 12% of the population, only 5% of participants are participating in trials on dementia. So there's lower representation of African Americans in trials in period. So we need to increase our participation among our community. And the benefit is really to support our next generation of improvements and advancement of this disease. It is disproportionately affecting our folks. So we know that we can play a huge role in this, and not only for ourselves, but also sharing this information with others that we know, as they protect our future generations, supporting the advancement of science, and then just overall helping our folks to find cures that work for us. Healthcare right now is a one size fits all. And so we are all unique, all come with different uniqueness and things that are different for us. One medication may be effective for one person, but will contribute to a better way of life. And so when we participating in clinical trials, we can look into the research that we can do. One of the major questions are trying to understand what could be the side effects or other risk of your participation in a trial. What if the treatment doesn't work for you? What would be the options for you? How much time and travel is required? And if benefits outweigh the risk. So last year, we worked with UCSF, so our whole collaboration was around the AHEAD study, which the aim was to study individuals before they got dementia. And so you had to have not had any signs of dementia after the testing to be able to test individuals. And the different types of dementia that Dr. Windom also talked about is the dementia is the umbrella phrase, and then there are different types of dementia. So Alzheimer's is the main one that is affecting over like 60 to 80% of dementia cases are Alzheimer's. And then you have the Lewy body dementia, vascular dementia, the frontal temporal dementia, and other Parkinson's disease. The AHEAD study is closed now, and Dr. Windom can probably talk about other studies. We were talking yesterday about another study that's ATP. I am not a Alzheimer's dementia expert. However, like I said, I'm the messenger and carrying the information to our community that we're informed so that we can be participants and make meaningful contributions. However, many of the studies have the same type of process. Of course, there's the information, understanding the criteria, understanding what the commitment is, and then there's usually an incentive that is given for the participation over a period of time. So just the pride of participating and just going through the process to just see. And if not, I can always share with people to increase our representation in clinical trials. So this is the qualifications that were for our AHEAD study. And as I said, it's closed now, but there are other clinical studies that you can participate in. So the qualifications for this particular study were that you were 55, between the ages of 55 and 80, and have not been diagnosed with Alzheimer's or another, have a close friend who can attend with you. The compensation was $50 per required visit. Also, the visits were once a month. The commitment, usually for some of the trials can be over years. So this particular one was over 4 years. It includes a 1 hour visit every 2 to 4 weeks in the clinic. Once a year visits with study partners, blood test, and urine test. Individuals received a monthly or every 2-week IV infusion, which is the medication that goes through the veins through a needle. There are pictures taken or imaging of the PET scans and MRI scans of the brain. And so, what are the benefits of the AHEAD studies and other studies is to, attention paid to brain health and the advancement of treatment and working towards a cure for dementias. Your participation will help to find treatment for Alzheimer's disease that works for everyone, and to learn about the risk of developing disease at a later stage. As a believer, I think about, Proverbs 4:7 that says, wisdom is the principal thing. So therefore get wisdom and with that, get an understanding. So to become informed about our options for our health, to be advocates for ourselves, and one very important for us to understand our current state so that we can work to the most ideal future state is very important for us to understand the risk and the benefits of clinical and being a participant and as well as understanding and being able to talk to individuals about their hesitation. Again, understanding that, acknowledging the past, the harm that has happened with our with our folks who have been harmed. And all of those individuals did not consent to the treatment. And so now in research, consent is the hugest piece, is that people are informed so that they can make an informed decision and consent to treatment, consent to everything that's involved in the clinical trial, which was what was missing in the past. And so I hope this presentation has provided you with information and giving you just even a little bit of information, looking at the historical viewpoint on research and participating as individuals, trying to understand and getting the most information so that you are armed with the power of wisdom and knowledge to make an informed decision about your life and, of course, about the future generations that are to come. So I'm wondering, as a result, would you consider participating in a clinical trial? Please put in the chat if you would. And as I close, I would love to answer any questions that you may have or any comments. Thank you so much for having me. Am I here? Can you all hear me? Oh.
Yes, we can hear you.
Okay.
No questions? Go ahead, Gwen.
Yes. What trials are open now? Because I'm interested, but what is open right now? Are you looking for participants?
Is Dr. Windom still on? So I'm going to pass that on to Dr. Windom if he knows of any at UCSF.
Sure. Yeah, so happy to share a couple of options. So in terms of research, So as Kim mentioned, we have both observational research as well as clinical trial research. From an observational research study standpoint, we have a number of different research studies. We have a healthy brain aging research study. We have a research study that's specifically focused on Alzheimer's disease. We have a research study that's also specifically focused on frontotemporal dementia. There's maybe 6 or 7, honestly, that are currently active and enrolling. In terms of actual clinical trials, so the newest clinical trial, it's not yet enrolling, but we're going to start enrolling for it soon, is called the ATP trial. In the ATP trial, and this goes back to kind of what I had mentioned earlier about amyloid and tau, right? So in the ATP trial, they're actually testing the combination of a medicine for amyloid and a medicine for tau combined together to see how much benefit somebody actually can potentially get from using both of these therapies. So that's going to be the newest trial that's going to be up and enrolling. Probably, we're almost in the summer, probably a little later in this year, give or take, a little later in this year, they might start enrolling. But that would be the newest clinical trial from an Alzheimer's standpoint.
Now, you talked about the positive things and how it's helpful. What are some of the things that, by participating in this, when you're signing on the dotted line, what are some of the effects that can happen?
Sure. Yeah, I'm happy to answer that. So I think in terms of clinical trials, there's a couple of things to really stress. So you do consent at the very beginning of the clinical trial. You do consent to participating in the trial. It's important to keep in mind, though, with clinical trials, it is completely voluntary. So at any point in a clinical trial, if you do not want to continue the trial, you can stop at any point. It can literally be after you've consented, and even say you get, right before you're about to receive, the placebo or the clinical medicine, you feel, I'm not sure about that. You can withdraw right then and there. So even if you're signing on the dotted line for your consent, you can withdraw at any point in time. And this is one of the medical protections that has been put in place because of the historical issues that Kim has mentioned, where nobody can force you to do anything without your 100% consent. In terms of the side effects, so these medicines, there really is one class of side effects in particular that we think about most. And that is, it's this class of conditions called ARIA. What I mean by that is that when you administer these medicines, so the medicines are actively removing a protein from the brain, right? They're removing amyloid, or they're removing tau. And so as a side effect, one of the things that can happen is you can have inflammation. You can actually have inflammation that develops in the brain. You can actually also have small bleeding events that do develop in the brain. In the research trials that they did before to approve the lecanemab medication, there were not an insignificant number of individuals who developed these side effects. So in lecanemab, they were looking at, it's the amyloid protein. About 25% of people developed the side effect. So it's a substantial number. The good news is that the vast majority of people, they were completely asymptomatic. They didn't feel any differently. So they had inflammation or had small bleeding events, but they were still going on about their day as if nothing had happened. How we knew they had a side effect is that they were doing very regular pictures of the brain. They were taking very regular MRIs of the brain. And so that's how they ultimately were able to determine that they had experienced, some level of a side effect. That's the most notable side effect. And that's the one that we think about the most. Sometimes you can have things like an infusion reaction, meaning as you get the medication, you get lightheaded or have low blood pressure, things like that. But the most notable one that happened at highest frequency was this ARIA. And again, it's related to you're pulling a protein actually out of the brain because of the medication. And so it's part of, the medication, potentially even in working the way it's supposed to.
And so these are the side effects that you see on medicines when you pick them up from the pharmacy and you see all these listings. These are the listings and some of the effects that have happened to people in the trial.
Exactly. So this is a good point of education, whenever you get a medication from the pharmacy that has been FDA approved that you are taking for basically purposes, the side effect profile that is listed for that medicine, that is generated from a clinical trial. Without the clinical trial, there would be no FDA approval of the medicine, but there also would be no side effect profile because we wouldn't know with regards to the side effects. And once the medication is out in the real world, we learn more about the actual frequencies of side effects and maybe other things that happen too. But our foundational knowledge that we use to guide folks and inform folks, it's all based on the clinical trials, speaking to how important it is that we have clinical trials to generate this information.
Okay, we have a question in the chat says, is there a study for the use of medical equipment on people of color? I heard the oximeter does not work as effectively on people of color.
I am not sure. I don't know, Kim, if you know more. I haven't heard of medical device trials specifically for folks of color.
I want to say that I have heard around that, like you're talking about the pulse oximeter that measures the amount of oxygen, okay, for your oxygen level. I've just heard, I haven't heard any detail. It could speak to that.
Okay, and then
Great
Reverend Randolph.
Yeah.
Oh, I'm sorry.
I was just great questions.
Reverend Randolph, you had a question because your hand is up.
I wrote in the chat, and yes, that I participated in study for aging African Americans before, and my thinking is that oftentimes with clinical trials, when we're looking at medications to alleviate certain symptoms, there aren't enough African Americans that participate. So the pharmaceutical companies, as well as the ADA, come up with medications that are germane to whatever population was in the study. And if we're not in it, then the medications as prescribed don't work as well on us. For example, heart medication or medications for high blood pressure. With that being said, I think it's vital that African American males and females participate in the studies for whatever ailments there are, so that as they're developing cures or medications, they'll take into effect how we function, how our bodies react to what's out there. Because other than that, we're going to suffer generation after generation after generation. I don't want to get on a soapbox, but I just say that I feel it's vital that we participate in health studies so that we can be a part of the cure and not an ongoing situation of non-contribution, and our children end up in the same or worse situations down the line.
Precisely. That's excellent. And thank you so much for participating in trials, as well as having the banner, because that's what's needed, especially those of us who have been a part of it and can speak from experience, can help, to influence individuals to participate. But precisely, if we're not a part or in the trials, then we won't have a treatment that works for us because we're not represented. Again, many of our treatments are for our white, counterparts, because that's who are participating in the studies. Thank you for that. I see a comment from Eddie Walker, who said she participated in a women's reproductive study at UCSF and found it to be insightful, that it requires time to carve out for the appointments and testing. Exactly. It can take up quite a bit of time. So, in the informational of knowing how much time is needed to participate in those trials, it can be a determining factor if it'll work for you or not. But very true. There's another question. Is it true that statin drugs affect brain and may cause dementia? Dr. Windom, what do you think about that one?
Yeah, so I think this has been kind of floating around, this question in particular. And, there's important things to keep in mind with regards to this. So what I mean by that is, if you look at statins and the association with dementia risk and things like that, there are many epidemiological studies. And what I mean by epidemiological studies is that they take thousands of folks who have a bunch of different medical conditions or on a bunch of different medications. Some of them have dementia, some of them don't, and they look at association. So they look at, okay, in this 3,000, group of individuals, the people who are on statins, how many of them have dementia? The people who are off statins, how many have dementia, and what's going on with them otherwise? So all of these studies, many of these studies where, and they've been coming out more recently, I think, where they're trying to claim that there's a link between, use of a statin and dementia risk, things like that. They're just large epidemiological studies. They're just showing association. Association or relationship is very different from causation. Causation is actually you take something or you do something, and downstream from that, this is what happens as a direct result of that. You can't look at an epidemiological study showing just some of these relationships and assume it's causation. So in these studies where they have shown there's maybe a relationship with statin and dementia risk, you can't read into those and say, oh, well, the people who are taking statins, they develop dementia because of taking statins. You can't do that in an epidemiological study. The other thing that's really important to keep in mind is that in these studies, so individuals who had higher rates of dementia who were maybe on a statin, you can actually think about, there's an explanation probably for that. People who had higher rates of dementia in those studies who were on a statin, those individuals maybe were on a statin because they had things like high cholesterol, because they had things like heart disease. And what did we just talk about as one of the risk factors for developing dementia? Vascular disease of the brain. So these people could have higher rates of vascular disease of the brain from a lifetime of high blood pressure, lifetime of high cholesterol, lifetime of heart disease that actually is driving their dementia. And they're on the statin to try to take care of some of those conditions. So I hope that kind of helps to clarify. When you look at these studies, you have to be very careful about thinking about causation. Just because there's a relationship doesn't mean one is absolutely causing the other. We can get into, a bit of trouble. And then the last thing I'll just say is, if you say you read one of these studies and you think, well, it looks like a statin statin's going to cause dementia. Me taking a statin is going to cause dementia, so I don't want to take it. But then you have a major heart attack or you have a stroke because you're not on a statin that's protecting you from that. And then because of the heart attack or stroke, you go on to develop dementia. It completely defeats the purpose of coming off the statin, right? So if coming off the statin reduces your risk of dementia by 1%, but increases your risk of a stroke or heart attack by 50%, and then that stroke or heart attack increases your risk of dementia by 60%, it's just a numbers game, right? You're actually, in the long run, disadvantaging yourself in terms of your risk of dementia because you've come off the medicine that's protective for you.
Any other questions, concerns? I'd see we have one other one in the chat. It says, what about head injury and dementia?
Yeah, so the data on head injury and dementia is scarce. Most of our information comes really from our ex-professional athletes. There's a lot of research that has been done looking at ex-NFL players and rates of things like CTE being chronic traumatic encephalopathy. The truth of the matter is, it's really largely still unexplored. So if you, for example, have 3 or 4 bad head injuries as a result of motor vehicle accidents over the course of your life, do you have an increased risk of dementia compared to someone who's had only 2 accidents or somebody who's never had an? We don't know. We think maybe, but again, this is all based off of folks who have sustained really high level impact to the brain on a professional football field or in a hockey rink, et cetera, et cetera. There are research studies actually at UCSF currently where we are trying to better understand what is the link between head injury and actually the development of dementia. Are there biomarkers? Are there specific tests we can do for people who have head injury that show that the brain is in a more vulnerable state or there's some other problem arising that's going to lead to dementia? It's really unknown largely, and we need, honestly, a tremendous amount of research in this area. It's an area we know very, very little about, and only the amount we know is from a very small group of folks who, again, I don't know if anybody on the call is a professional NFL athlete, but I would argue none of us sustain the level of head trauma that they do, even on kind of a day-to-day, week-to-week.
I had a quick question, and it is, I'm sorry, Patricia. It is the relationship between medications and dialysis. Maybe I'm not saying the right words, but dialysis and medication, or excessive medication and dialysis.
So let me see if I understand. So the question is maybe, do excessive medications or the wrong medications contribute to the development of kidney failure that leads to a need for dialysis?
Yes, you said it's so great.
Yeah, I mean, I think so. Kim, this may be more in your wheelhouse, but I think in terms of the most common causes of kidney disease in the U.S. that lead people to a point where they need dialysis. Again, this is me guessing in part because I'm not a nephrologist, but I would say they'd have to be hypertension and probably diabetes second. And then you have the host of other conditions. And so you probably need to be on medications for high blood pressure and diabetes, and probably maybe on actually a number of them if the blood pressure and diabetes are difficult to control. And so that's where you could end up with a lot of medicines. They may not necessarily cause the need for dialysis itself. It's more so the failing kidney, although there are some medicines that we consider nephrotoxic, meaning they're toxic to the kidney. And yes, they can result in substantial damage. But I would say by and far, it's probably high rates of high blood pressure, high rates of diabetes, and that being not well controlled, and that damaging the kidney over time, resulting in a need for a lot of medicines, but also a need for dialysis.
I would agree with you, Dr. Windom, as well as, there are some medications that people are on, and so their ongoing monitoring of that is to check their kidney function to make sure that it's not nephrotoxic, and then to view to explore other options if it is causing harm to the kidney.
Well, we have so many dialysis companies now all over. It's almost like Kentucky Fried Chicken. So, I mean, franchise all over the place. So I can't understand. You mean that high blood pressure and these things that you're talking about is so out of control that way that we have?
Yes. Yes. Especially among our people. So, doing the simple things of moving, what we eat, and the stress monitoring, keeping our stress low, that all those things contribute to heart disease, which are, hypertension is like the number one cause of kidney failure.
Wow.
We have two people who have their hand up because we want to make sure we finish up at 12 noon. So Reverend Randolph, you, and then we're going to have Delois Deloney next.
Thank you. I'll try to be as brief as I can. In 2018, I had 2 simultaneous head-on collisions, and my head hit the windshield with such ferocity that I had traumatic brain injury. And they said that I had the type of injury of somebody that had played NFL football for 10 years. So I'm taking a bunch of medication, have been taking a bunch of medication since 2018. And they monitor my kidneys continuously. Matter of fact, I have to go get a blood test Monday to see what's happening, because I'm taking this medication that normally I've been taking Tylenol 3 times a day since that time. And the question Sister Gwendolyn asked is, with all of the medication and with the traumatic brain injury, can that lead to both diabetes or the lack of a need thereof, as well as kidney failure, as well as Alzheimer's or dementia? Yeah, that's where I'm at with the question.
You say you're taking Tylenol 3 times a day? Are you taking ibuprofen as well, or just the Tylenol?
Say that again, Dr. Windom.
You said you're taking Tylenol 3 times a day. Is it just Tylenol, or are you taking ibuprofen as well?
I am not taking ibuprofen. I was prescribed um, well, another medication, naproxen, which I don't take very much, but I take Seroquel, gabapentin, and a bunch of other stuff that on a daily basis. And I guess the last part of this is, will taking ginkgo biloba help me retain any of my brain functioning?
Yeah, so yeah, it looks like Pete kind of beat me to the punch. So in terms of the, which medications are toxic to the liver, which are toxic to the kidney, so taking Tylenol regularly, that can be problematic potentially for the liver, depending on the dose that you're taking and how long you take it for. And then the kidney medications are more so the NSAIDs, so non-steroidal anti-inflammatories. So things like ibuprofen, things like naproxen, those can be more kind of toxic to the kidney in particular. To your point about ginkgo biloba, and Kim, if you have other thoughts on the nephrotoxic, but I'll just quickly, the ginkgo biloba component, there's no research study to date that has shown any sort of supplement that we take for brain health makes a meaningful difference in terms of preventing cognition change, memory loss, dementia. Prevagen, Nariva, ginkgo biloba, brain boost, whatever you want to call it, you buy from Amazon. None of it makes any difference. There's no evidence, there's no research to suggest it makes any difference. A lot of times we spend money on it and it honestly doesn't do anything.
Okay, our last question is from Dolores Deloney, and we're going to wrap it up. Sister Deloney?
Okay, this is Kim Deloney, her daughter. So I'm in place of her. My question is that with the change of the way that we move in society these days, is that our ability to multitask has increased 20-fold. And I was wondering if our ability to multitask at such a high volume has anything to do with dementia, or even increasing the probability that you could end up with dementia, because I noticed that a lot of people forget a lot of things, and it's not just starting when someone is getting to their senior years, it's earlier than that. And the only thing that I see that is common is the ability to multitask, or well, the lack of the ability to multitask to the degree that we are, and if that had something to do with it. And I also wanted to ask you, so part 2 would be with the studies and so forth, and I'm a public health officer, so we feed them a medication that helps to do this. And then we have to go back and we have to look at, okay, we're going to give this, but it has a probability of causing these symptoms. And so we get this under control. And now this part of what that side effect is now being enhanced in the person's body. And we're talking about seniors here. So we're talking about our bodies have went through some things already. So at this stage, I'm playing with medication, and toxicity to the liver and the kidney is most indefinite. It's going to happen. So in the light of trying to not convince us, but to tell us the reasons why it's positive to participate in studies, even based on the fact that African Americans don't participate in the studies as much, but we do participate in studies. So at this point, it's hard to convince African Americans when we're starting to think of how medications that have, for one practice, has a side effect that may cause another issue in a body that's already experiencing dementia and Alzheimer's. And then we're trying to add these positive aids to subside those negative side effects from that medication that's supposed to do the right thing. So I'm just asking if you can clear some of that up. Dr. or Miss Nurse Kim.
Yeah, sure. I'm happy to offer some thoughts. So I think to your first question, in terms of the idea of multitasking and incidence of dementia, that's not 100% clear to me. I think many people wonder, why is there such greater prevalence now of Alzheimer's and dementia than there used to be, so to speak? And is it related to something like us multitasking more, et cetera, et cetera? I don't think it's actually that. I think really what it is we have much better ways of detecting whether or not somebody has Alzheimer's. And the other big thing is people are living longer, right? People are living far longer now than they have lived at any point in history. And age is the greatest risk factor for developing Alzheimer's. Age is the greatest risk factor for developing any type of dementia. So it's just a byproduct of people being around for much longer. It's not necessarily that lifestyle-wise things are so much different. Yes, the advent of technology is huge, but again, we just talked about association and causation. It's hard to say. You can't necessarily say just because folks are multitasking more, that's causing greater rates of dementia. We don't know without an actual study following people 30, 40, 50 years over the course of time. To your other question about, side effects and is participating in a trial worth it given the side effect risk profile? So a couple of thoughts just with regards to this, just side effects in general. We tend to associate and we tend to kind of, when it comes to side effects, we think of the worst case scenario. And yes, none of us want to experience a side effect. Absolutely, that is the truth. But I want to challenge you and suggest that many of the things we take each and every day without thinking about it, they have substantial side effect profiles. Aspirin, for example. Number of folks on this call probably take aspirin. Aspirin is tremendously powerful in terms of its ability to stop your blood from clotting. You can have a substantial bleed from aspirin and die as a result, actually, of a bleeding event from aspirin. But we take aspirin every single day like it's nothing. Again, it's the idea of that, nobody wants to experience the substantial side effects, but the things we take on a regular basis that we find oftentimes are harmless or think are harmless, that's not the case at all. Many supplements that folks take over the counter also, they actually dramatically increase or decrease your body's ability to clot. There are some supplements you can take over the counter that substantially alter your body's ability to clot. And again, you can have a major bleeding event actually on one of these supplements. But because, again, we take it so regularly and because it's marketed as natural, we don't think that the side effects are that substantial, but they really are. So there are a lot of things we actually take where there's a tremendous risk of a side effect occurring. Yes, the medicines and clinical trials are very different. The medicines and clinical trials we're still learning about, we're still exploring. I will say, though, that the medicines and clinical trials, they offer a medicine and a solution to something we otherwise don't have an answer for very frequently. So in Alzheimer's and dementia, for example, we do not have a way of removing the amyloid and tau proteins from the brain outside of these medicines. All we have currently is these medicines. And so if it's not through a clinical trial or what's kind of FDA approved already in lecanemab, the actual other option is just to let the damage and let the proteins continue to accumulate. And there's no evidence that we have that has been published to date that shows that the proteins will magically go away or will stop accumulating. That is not what happens. They get worse and worse over time until there's more and more dysfunction. So it's a complicated question. It's a bit of a nuanced answer, but hopefully some thoughts that are maybe helpful and informative.
Thank you very much, Dr. Windom, for explaining that. I'm looking at my computer, and right now it's 12:01, and the workshop is supposed to end at noon. So I'd like to, and I know that Nurse Pete had some questions that he wanted to ask, but I think in order to be respectful of everyone's time, I think we're going to let Sonia go ahead and give us our closing prayer. Again, thank you. This will be on the church's website so people can review this or refer other people to watch this, because there was some very, very good information for those who didn't come on that I invited. I can at least forward this information. So Sonia, who is a member also of Allen Temple, who works with our youth and does so many amazing things at our church, we'd like for you, Sister Sonia, to go ahead and lead us in closing out this session, please.
Thank you, Sister Pam. Thank you, Allen Temple Health Education And thank you for this webinar for Alzheimer or dementia. Most gracious Father, I thank you for today. I thank you for the wealth of knowledge, of information that Sister Letty started out asking. I have a lot of questions. I would suffice to say that those questions have probably been answered and even more. So thank you, Dr. Windom, Nurse Kim, for pouring into us. I too have lost a mother to dementia, and I've learned so much going through that journey. And I would suffice to say that a number of us are rethinking the opportunity to participate in clinical trials because we are a people who do not believe in fear because it's false evidence appearing real. And that is not what we are about. So, Father, I just ask that you continue to bless this ministry. Bless each and every household that is represented here today. In Jesus' name I pray. Amen.